cytoplasm. So this is the classification from the 4th edition of the WHO classification of hematolymphoid malignancies. So I just want to go very quick to the references I'm going to use throughout the whole session. So just be aware, and these are the preferable study sources I use myself during the preparation for APCBC board and the subspecialty hemopath board. These are the common references I would recommend definitely everyone taking the board exam to go over. WHO, which is the blue book, also called blue book, and also this another hematopathology review book. This is also an excellent resource. This is another question book, and also there is another hematology outline atlas. That's very helpful resource and interactive source. So now let's dig into the questions. I'm gonna present my talk today in format of questions and answers, and we go from there. So that's what I'm gonna do. So technically, as I mentioned earlier, myelodysplastic syndrome, usually hypercellular marrow, but the patient presents with cytopenias. Myeloproliferative neoplasm, again, hypercellular marrow was cytosis in the peripheral blood, and this is an overlap syndrome between MDS and MPN. It can present with either one, cytosis or cytopenias. And the patient, any of these patients, if left untreated, they can progress definitely to acute leukemia. And this is just a little table. I want to show the differences between MDS and MPN. So both can look under the microscope with hypercellular marrow, but the peripheral blood findings are totally the opposite. So in MDS, because there's ineffective erythropoiesis or granulopoiesis or thrombocytopoiesis, so patient presents with cytopenia. Usually in myeloproliferative neoplasm, there is marked proliferation of cells in the bone marrow, and all these cells can be extruded into the peripheral blood, so the patient presents with cytosis usually. And all these categories, MDS, MPN, MPN, and MDS, if left untreated, they can progress to the worst case scenario, which is an acute myeloid leukemia. So starting with MDS have some specific dysplastic morphologic features we can see in the peripheral blood or the bone marrow. And the one we usually depend on the clinical practice in the peripheral blood are granulocytes. So we can see hypogranularity, hypo or hypersegmentation, acquired pseudopilgrim abnormality. So these are the common things. And also we can find the bone marrow findings, especially in erythroids or platelets. We can or megakaryocytes. You can see this in the bone marrow. I'm gonna present some pictures that might help to simplify this. So normal megakaryocytes should have a single nucleus that is multilobated, but if it has a single nucleus that is monolobated or hypolobation, that's a dysplastic feature. Also, separation of the nuclear lobe in a megakaryocytes is another dysplastic feature, as we can see right here. Also here, there is hypolobation or separated nuclear lobes. Megakaryocytes can be very small and hyperchromatic, as you can see in this picture in MDS. This is an aspirate smear. You can see the megakaryocytes, they have separated nuclear lobes. That should not be happening, especially in the aspirate smear. Try to be cautious while looking at the core biopsy, because sometimes tangential cut in the core biopsy might give a false impression of separated nuclear lobe or hypolobation. On the peripheral blood, the neutrophils, when they become hyposegmented like this, we call them polymorphic nucleoleucocytes because they have multiple segments in their nucleus. If they are hyposegmented like this one, that's a dysplastic features, as best appreciated on the peripheral blood. This is a pseudopilgrim cells, and it's also characteristic abnormality in MDS. We can see that a lot in MDS, but make sure that's an acquired. It's not a congenital, because congenital pilgeroid cells can be a separate thing. Also, nucleocytoplasmic dyssynchrony, meaning that the nucleus and cytoplasm, they are not growing in the same direction. I mean, that nucleus is still immature while the cytoplasm is maturing, or vice versa. These are some pictures. Also, loss of myeloperoxidase. Myeloperoxidase here in yellow. If we lose this, this is another specific feature, but this is kind of not commonly used one. In terms of erythroids, if we see the binucleation, nuclear bridging like this one, multinucleation in erythroid lineage, that's dysplastic features. Cytoplasmic vacuolization is also another dysplastic feature. A ringed pseudoblast is also another dysplastic feature when we do iron stain on the aspirate smear. So what are the minimal diagnostic criteria for MDS? For MDS, we have to have a sustained cytopenia that's not explained by anything else, like we know the patient is not taking chemotherapy or any other reason, specific infection or something that can cause the cytopenia. So if there is sustained and unexplained cytopenia for at least 6 months, and these are the numbers you should be familiar with for each cell lineage. Plus, in addition to the cytopenia, we have to have at least one of the following. First thing is dysplastic morphology, as I showed in erythroids, granulocytes, or megakaryocytes, and the cutoff is 10%. So at least to call it dysplastic change, we have to have at least 10% of each cell line to call it dysplastic line. Dysplastic megakaryocytes, at least 10% of the megs are dysplastic. Also, acquired clonal myelodysplastic related cytogenetic abnormality, which I will discuss right here on this table. Or increased blast at least 5% on the bone marrow cells without known cause like growth factor administration or something like this. That also can be one of the diagnostic criteria for MDS. What are the recurrent cytogenetic abnormality that we commonly see in myelodysplastic syndrome? Gain or loss of certain chromosomes. This is a very common thing. -7 or monosomy 7 or deletion 7q, monosomy 5 or deletion 5q, trisomy 8, trisomy 21 or deletion 21, isochromosome 17 or deletion 17, deletion 20, deletion 11q, deletion y. These are the common things, but the most common of which are monosomy 7 and monosomy 5. We have one category of MDS is called isolated 5q deletion. And monosomy 7 is also one of the characteristic things in MDS. Other less common ones are the deletion 20, trisomy 8, and -y or monosomy 1. That's a problem here. If we lack these ones are not specific for MDS per se, and they can happen with other conditions. Especially deletion 20q can be seen in older patients even without MDS. So you have to be extremely cautious which one is highly important or which one is common in MDS and kind of more specific and which one is less specific. So these are the categories of the MDS based on the 4th edition of WHO, and I think per the latest guidelines for the board exam this spring season, you are not required to know the latest, which is the 5th edition of the WHO or International Consensus Classification of Hematolymphoid Malignancies. But I think starting 2024, all residents taking their board should be aware of the new classification system. So MDS with unilineage dysplasia, that means that we have at least one cell line dysplasia, and dysplasia means at least 10%, and we don't have a lot of blast in the peripheral blood and less than 5% in the bone marrow, no aurorads at all, and no ring sideroblast. If we start to see ring sideroblast, we call it myelodysplastic syndrome with ring sideroblast and unilineage dysplasia. Definition of ring sideroblast, you have to find at least 15% ring sideroblast in the aspirate smear, or more than 5% if we have the SF3B1 mutation. This mutation is important. You need to memorize for your exam. And also can be multilineage dysplasia with or without ring sideroblasts. And then myelodysplastic syndrome was excess blast 1. Here, the cutoff 2 to 5% in the peripheral blood and or 5 to 10 in the bone marrow. 2 is 5 to 19 and then 10 to 19 in the bone marrow. Plus or minus our rods here we can see only an EB2. In the subtypes of MDS. MDS was isolated 5q. That's a common question. The board loves this question. Anemia. Usually there is thrombocytosis or increased platelets, usually elderly females, and they have isolated 5q deletion. Can be isolated or with other cytogenetic abnormality, except if we have monosomy 7 or deletion 7. If you have both deletion 5q and monosomy 7, you cannot call it isolated 5q deletion. They have hypolobated or mononuclear megakaryocytes, and they are kind of characteristic for this type. MDS therapy related if the patient is receiving chemotherapy or ionizing radiation. Refractory cytopenia of childhood, it has multilineage dysplasia and cytopenia with low blast counts. And if we have MDS that does not fit in any one of these categories, we call it unclassified. There's some categories we also need to be familiar with, like idiopathic cytopenia of undetermined significance, or ICOS. So we have cytopenia definitely, and we might have some clonal or genetic abnormality, but we don't have dysplasia, or we do not have defining cytogenetic abnormality, that like the ones I discussed earlier, like monosomy 7 or monosomy 5. Also here, clonal hematopoiesis with undetermined significance or indeterminate potential. This one, CHIP, we might have some cytopenia, and we have clonal abnormality, and it's common in some in old age in general. And idiopathic dysplasia of undetermined significance, also idiopathic dysplasia if we have some dysplasia, but we don't have cytopenias. So now let's go over questions to make it simple and easy. Which one of the following is the most useful establishing myeloid lineage in acute myeloid leukemia? So for myeloid leukemia, is it CD13, CD33, myeloperoxidase, or cytoplasmic CD3? So the one that is lineage specific on all of these options is myeloperoxidase. Despite we can see CD13 and 33, myeloperoxidase is the one that is lineage specific. So acute leukemia workup, usually when you see an acute leukemia case, you do CD34, however, it can be negative in some cases. Then you do another myeloid markers like CD117. If it's lymphoid leukemia, you have to do TDT, which is lymphoid marker, then PAX5 for B lineage, and CD3 for T lymphoblastic leukemia. So this table is from the WHO book. As I mentioned earlier in my discussion, my references, we have 4 references I mentioned earlier in all the tables I'm sharing throughout the whole video today. These are my references for the whole talk. So this one is from the WHO, the 4th edition of Hematopoietic Lymphoid Malignancies. So the myeloid lineage specificity is MPO. The T lineage specificity is cytoplasmic CD3. And B lineage is strong CD19 plus one of these, CD79A, cytoplasmic 22, or CD10, or weak CD19 plus 2 of these markers. So if we have myeloid markers and lymphoid markers, what do we call this? We call it mixed phenotype acute leukemia. Just to be aware, some acute leukemias might not have CD34, including the acute leukemia with monocytic features, acute promyelocytic leukemia, AML M7, the megakaryoblast leukemia, PBDCN, and NPM1 mutated acute leukemia. So acute leukemia can be myeloid, acute myeloid leukemia, or could be lymphoid, B lymphoblastic leukemia, or could be T lymphoblastic leukemia, or it could be the mixture between myeloid and lymphoid line. We call this mixed phenotype acute leukemia. Also, blastic plasmacytoid dendritic cell neoplasm, and also acute undifferentiated leukemia if it does not fit any one of the categories. Acute myeloid leukemia with recurrent genetic abnormalities. This is one of the things that you might encounter in your board exam, like questions about the acute myeloid leukemia with recurrent genetic abnormalities or recurrent gene mutations. So which one of the following, if you find this molecular abnormality, it's equivalent for acute myeloid leukemia regardless of blast count. So you don't have to have that 20% cutoff. So it's translocation 821. So we have 3 types of acute myeloid leukemia. We don't need the 20% cutoff, including the 821 translocation, the 1517 translocation, and inversion 16. Another question for AML with recurrent genetic translocation, we have acute myeloid leukemia with increased eosinophilic precursors with abnormally large basophilic granules. This is characteristic for subtype of acute myeloid leukemia. Which one of the following cytogenetic abnormalities? We can see this one. This one is most commonly seen in inversion 16. I'm going to show you a picture. This one, this is also from Javis book. This is the one of the references I mentioned earlier in my talk. We can see eosinophilic precursor with deep purple or violet granules. And these are very characteristic for this acute myeloid leukemia subtype with inversion 16. Also, which one of the following engine is not typically expressed in acute promyelocytic leukemia with PML-RARA? So PML-RARA usually lack the 34 and DR, so DR should not be there. It definitely does have 13, 33, and MPO. MPO should be strong. And acute promyelocytic leukemia, which is considered as a medical emergency, we have to treat the patient as soon as we can because the patient might die if they're not treated immediately or as soon as possible. And they are treated with arsenic and atra. So the morphology is very important. So we see the bilobed nuclei of the abnormal promyelocytes. They have the granules. You might appreciate sometimes our rods in these cases. And we have to do also look at the morphology, flow cytometry, the lack of 34 and DR, and also increased side scatter in the flow cytometry are important and helpful features. But the most accurate thing is to do a stat FISH cytogenetics or PML-RARA. We have two different subtypes of acute promyelocytic leukemia, the hypergranular variant and the hypergranular variant. This one has low blood count. This one has white count is elevated. Both have a similar morphology. And this one has a lot of granules, as its name implies. This one, no granules, but they're both strongly positive for MPO. This one doesn't have 34 or DR. This can express dimmer 34 or DR. Another question for the recurrent genetic abnormalities in acute myeloid leukemia, you might see a picture like this. Acute myeloid leukemia, you can see some pictures like this one. The nuclear indentation or cup-like nuclear features or fish mouth. This is commonly seen in mutated NPM1. B-lymphoblastic leukemia or lymphoma. One of the questions they might ask you about the favorable or unfavorable prognostic features. So what is unfavorable prognostic feature in child with B-lymphoblastic leukemia or lymphoma? Age of 6 years, translocation 1221, KML, MLL or KMT2 GA gene rearrangement, or lack of CNS involvement at time of presentation. So the one that does have unfavorable prognostic factor is the presence of MLL. These are the poor prognostic factors in B-lymphoblastic leukemia. If the age is less than 1 year or more than 10 years, if the white blood cell count at the time of diagnosis was high, especially about 50,000, if there is slow response to initial treatment, after we give the patient initial treatment chemotherapy, we do morphologic assessment of the blood or bone marrow. Also looking at the MRD after therapy, if we still have minimal residual disease, that's a problem, and that confers adverse prognosis. If we have CNS involvement at the time of diagnosis, also it's bad. That's why we do a lot of CSF sampling for patients with B-lymphoblastic leukemia to make sure that we don't have blasts in the CSF. Presence of intrachromosomal amplification of one copy of chromosome 21. These are the poor prognostic factors. B-lymphoblastic leukemia also have some types with recurrent genetic abnormality. Which one has marked peripheral blood eosinophilia? So the subtype that does have peripheral blood eosinophilia is the one with translocation 514 because it does have the interleukin 3, which increases the peripheral blood eosinophils. Question about the T-lymphoblastic leukemia. Detection of which one of the following engine is diagnostic for T-cell differentiation in acute myeloid leukemia? Which one is lineage specific? This is another format for the question. Again, cytoplasmic CD3 is the characteristic lineage specific marker. So lineage specificity in acute leukemia is a really important question in the clinical practice and in your exam as well. So this is another important question here. So we have a bone marrow shows sheets of immature appearing cells with this phenotype. CD1A is negative, cytoplasmic CD3 is positive, so this is lineage specific for T lymphocytes. So we have T lymphoblastic leukemia, at least element of T lymphoblasts going on here. And then we have CD13 and CD33. These are myeloid, but they are not specific for myeloid. So try to be very cautious about this. We have CD34, we have CD117. It's again another myeloid, but it's not specific. The lineage specific marker for myeloid MPO is negative in this case. So what do you think? It does have T lymphoid markers, and it does have some myeloid markers, but not myeloid lineage specific markers. So what do we call this entity? This entity is subtype of T lymphoblastic leukemia, which is called early T precursor acute lymphoblastic leukemia. This entity should be separated from the regular T lymphoblastic leukemia because it does have different prognosis. And the tricky part here is the presence of some myeloid markers. Yes, some myeloid marker can be seen in this specific entity of T lymphoblastic leukemia, which is called early T precursor acute lymphoblastic leukemia. Questions about MDS. We have a 70-year-old man present with pancytopenia for 6 months. Bone marrow is performed, shows dysplasia of the 3 lines, granulocytes, erythrocytes, and megakaryocytes. Blast count is low, less than 1% in peripheral blood, less than 5% in the bone marrow. So if we have low blast count, we don't call it excess blast, either 1 or 2. And then also we have trilineage dysplasia. So we call it myelodysplastic syndrome with multilineage dysplasia. And it's not acute myeloid leukemia yet because the blast count is less than 20%. Another question for MDS. 70-year-old man with pancytopenia for 6 months. Bone marrow is hypercellular, but there is no significant dysplasia, just hypercellular bone marrow with pancytopenia. Which one of the following cytogenetic abnormality would be considered presumptive evidence of MDS diagnosis? As I mentioned, deletion 7. These 3 are not specific. For myeloproliferative neoplasm, which one of the following abnormalities is not seen in primary myelofibrosis? JAK2, BCR-ABL1 fusion, CARL mutation, carretin mutation, or MPL mutation. Any of these can be seen except for BCR-ABL. This is only seen in chronic myeloid leukemia. So these are just like my own tables from different resources. I put them together. I try to make for myeloproliferative neoplasm your own tables like this to know what are the different types of them. And also this is chronic myeloid leukemia. They usually tend to have a lot of myelocyte bulge, increased myelocytes, increased abnormal localization of immature myeloid precursors, small dwarf megakaryocytes. And the characteristic thing in chronic myeloid leukemia or the typical CML is the presence of BCR-ABL positivity. MDS-MPN, the overlap syndrome, features expected in a case of atypical CML include which one of the following? Dysplasia in the granulocytic lineage, presence of Philadelphia chromosome, monocytosis, or basophilia. Atypical CML is one of the subtypes of MDS-MPN. It does have this granulopoiesis, so answer A is the correct answer. Philadelphia chromosome, by definition, should be negative because atypical CML should lack BCR-ABL. If it does have it, we call it typical CML. Monocytosis, we usually see it in chronic myelomonocytic leukemia. Basophilia, we see it usually in chronic myeloid leukemia. Mastocytosis. Mastocytosis, neoplastic mast cells should be positive for which one of the following? Should be positive for CD25. CD20 is a B cell marker, CD3 is a T cell marker, CD117 is positive in early myeloid, early erythroid, and mast cells as well, but it's positive in both neoplastic and benign mast cells. Mast cells, you can see some focal aggregates of mast cells, spindle cell aggregates like this one, and they are beautifully looking here in the aspect smear dark granules like this one. These are the mast cells. They stain very strong with the CD117, also known as CD-KIT or C-KIT, and this is the activating mutation in this disease. Mast cell tryptase should be positive. CD25 and CD2 highlight the neoplastic mast cells. Mastocytosis could be only cutaneous if it does not fulfill the requirement for systemic mastocytosis. It should have multiple aggregates or multifocal aggregates of mast cells and does have different skin lesions. Systemic mastocytosis should have major criteria or minor criteria. Major, we have multifocal dense aggregate, more than 15 cells aggregate in the bone marrow or other extra cutaneous sites, and minor criteria either depending on the morphology, abnormal morphology of the mast cells, more than 25% of them are immature or atypical or spindle-shaped in the core biopsy. KIT mutation, any KIT mutation right now is considered an abnormality. Presence of CD25 or CD2, the latest update, they consider CD30 as well as an abnormality, can be seen in neoplastic mast cells. Serum tryptase, if it's more than 20 nanogram per milliliter, it's also another abnormality if it's unexplained. This diagram I adopted from the Hematology Outline Atlas, and this is one of the references I referred earlier in the session. It shows you the different morphologies. You should be familiar with different morphologies like microcytic anemia, macrocytic anemia, what causes elliptocyte, what causes schistocytes. These are kind of the things that might show up on your board exam, so you need to be familiar with this. You can use some mnemonics like this one: Spersas, post-splenectomy, A-beta lipoproteinemia, liver disease, and Myeloid. So I love to use some mnemonics just to memorize these important morphologic features. Again, the same Hematology Outline Atlas I mentioned earlier. It does have the different inclusion bodies you can see in erythrocytes. You need to know the component of each one of these inclusion bodies, like Haut-Jolly bodies is formed of DNA, Heinz bodies is hemoglobin. So you need to be familiar that the composition of each one of these inclusions and the conditions associated with it. Questions about the lab errors in hematology. When the uncorrected white blood cell count is higher than the corrected white blood cell count, what is the most likely cause? If you find a lot of white cells more than we actually see, so what can cause this? Presence of nucleated red cells, because the automated machine cannot recognize the difference between nucleated red cells and white blood cells, so they count them as white blood cell. Blue peripheral smear, if you see blue peripheral smear like this one, what do you think? That could be a rouleau or gamma monoclonal gammopathy. Megaloblastic anemia, if we have a patient with sickle cell disease and this patient has macrocytosis in the peripheral blood, so what is the most likely explanation? Most likely explanation, the patient is being treated for sickle cell anemia. They usually are under hydroxyurea, which is antifolate and can cause this macrocytosis. Another question for macrocytic anemia, we have a patient 50-year-old, MCV is high, 105. Liver function test elevated GGT, gamma GGT. This is an important enzyme you need to remember. Also, the patient have the bone marrow shows some ringed sideroblast and erythroid multinuclearity, which is kind of morphologic dysplasia, and vacuolization of the erythroid precursor, also another dysplastic feature. But here, the problem is the cytogenetics for MDS is negative. So this is not the case of MDS then, and the macrocytosis and other dysplastic features can occur in excess alcohol intake. So you have to be familiar with all causes that can cause morphologic dysplasia. PNH or paroxysmal nocturnal hemoglobinuria, which one of these statements is wrong about it? PNH is transmitted as an X-linked recessive? No, PNH is not an inherited disease, it's an acquired disease. So this is wrong statement. Yes, it can be diagnosed by flow cytometry, as I'm going to show in a minute. It used to be diagnosed with the Ham test, Ham acidified serum test, and it's due to mutation of PIGA gene mutation. And this is a common flow cytometric findings here. If you find the lack of 55 and 59, this is a common exam question on erythroid. And also you have to be familiar with this disease. PNH does not affect only erythroid, can affect also granulocytes and monocytes, and these markers can be lost on these surfaces. Slab cheek syndrome. So we have a child with hereditary spherocytosis, slab cheek. Reticulocytic response to anemia is inadequate. a bone marrow examination is most likely to show which one of the following. So slab cheek syndrome or Zeola erythema infectiosum, this is one of the viral infection kits caused by parvovirus. It does not affect all cell line. It affects only pure red cells. So it's only affecting red cells, and it's problem with the production of the red cells. Doesn't cause hemolysis. It decreases erythropoiesis and cause giant erythroblasts when intranuclear inclusions, as you see in this picture. And this is also adopted from hematology outline. It's very, very common picture you might see in your board exam. And slab cheek fever, as we call it. Cold agglutinin disease. Which one is, we can see this one. Is it an IgG disease in nature? Cold agglutinin, as you see? No, it's an IgM. Is it caused by pneumonia due to Staph aureus? No, it's mycoplasma. Red cell agglutination occurs in vivo? No, it's actually in vitro. Analysis of CBC can yield low red cell count. That's true, because the red cells clump together and they give false number. But the hemoglobin levels are normal. Why? Because to do hemoglobin analysis, we have to lyse the red cells. So agglutination doesn't matter in this case, and it's going to be very accurate. MCV will be falsely high. You have to be familiar with what are the false high and false low MCV. False high white blood cell count, false low white blood cell count, false high platelet count, false low platelet count. Hemoglobinopathies. Moving on to the other questions of benign heme. Hemoglobin H is deletion of how many genes of alpha thalassemia, or 3 alpha genes. Low hemoglobin A2. An individual undergoing hemoglobin electrophoresis method and hemoglobin A2 is at low level. The following are causes of low A2. Is it alpha thalassemia, delta thalassemia, iron deficiency, or all of the above? And the answer here is all of the above. Because hemoglobin A2 is composed of 2 alpha and 2 delta. So lack of alpha in alpha thalassemia or lack of delta thalassemia can cause low A2. The clinical problem in this condition, if the patient has alpha thalassemia and in the meantime, he does have beta thalassemia usually the patients have high hemoglobin A2. So if this patient does have any one of these conditions, iron deficiency and beta thalassemia, so the A2 might be falsely low, so it can mask the elevated A2 in beta thalassemia. These are less of cause of increased A2. Beta thalassemia should be on the top, and causes of decreased A2 hemoglobin. Hemoglobin S disease, patient with sickle cell can exhibit target cells and Howell-Jolly bodies in the peripheral blood. So what are the most likely explanation for Howell-Jolly bodies? It's autosplenectomy. So this is picture, these are actually my own pictures, circulating necrated red cells and polychromasia if the patient is hemolyzing. And then we can see target cells as well in sickle thalassemia. You can see sickle cells like this one. You can see the Howell-Jolly bodies. So these are all kind of morphologic features can be seen in patients with sickle cell thalassemia, especially with post-splenectomy. These are all my references I used throughout the lectures. Again, the WHO book, the 4th edition for hematolymphoid malignancies, and the Hematopathology book. This one also is a very, very useful resource. I adopted most of my tables from this one, and this is also another very useful resource for questions, preparation for your board exam. It's extremely helpful. Hematology Outline Atlas, and this is the link for this website. It's also extremely helpful for red cell morphologies and different diagrams of maturation of different cell lines. Thank you so much for listening, and I'm happy to take any questions.
Thank you so much, Dr. Meawad, for your excellent talk covering different aspects of hematopathology. So let me see if I see some questions online. 1 second. There is one question is talking about, somebody is asking about what translocations are associated in leukemia with good prognosis.
So in leukemia with good prognosis, 12 to 21 usually tend to be one of the good the ones with favorable prognosis. So 12 to 21 is usually a good prognosis.
And yeah, at the same time, there is another question also, like which are the leukemias that one needs to know which are associated with poor prognosis?
Yeah, poor prognosis, KMT2A or MLL rearrangement is one of the poor prognostic factors. So usually when we see a high-risk acute leukemia case, whether it's a new case or a case that has not been done molecular testing before, we love to do high-risk profile or KMT2A rearrangement or MLL rearrangement. And this applies to both B-lymphoblastic leukemia and acute myeloid leukemia.
Right, and one of our viewer wanted to know about atypical CML. So do you want to say something about that?
Yeah, sure. A typical CML, one of the defining feature of it is lack of the BCR-ABL. So BCR-ABL is a good exclusion criteria for it. And usually the patient tends to present with dysgranulopoiesis. This is one of the most common feature we see in a typical CML. And they can have some hypercellular marrow. They can have also increase in the left-shifted granulocytes in the peripheral blood, but most common feature is this granulopoiesis. So that's why we call it's an overlap syndrome, because there is proliferation of the bone marrow as well as dysplasia. So it's an MDS-MPN overlap syndrome.
Right. So regarding myelodysplastic syndrome, I can see one question about ring sideroblast. So, I mean, refractory anemia with ring sideroblast. So, I mean, what is the correct definition for it?
So, ring sideroblast, as far as this board exam goes, we have to have at least 15% ring sideroblast if the patient does not have SF3B mutation, and more than 5% with the SF3B1 mutation. But recently, in the 5th edition of WHO, they start to put a single entity called SF3B1 mutated MDS, regardless presence or absence of ring sideroblast. But I think for the Society of Hematopathology, they decided not to include the latest classification of WHO and ICC classification for this spring exam, for board exam. But I think starting 2024, they will include the latest classification for that one.
Right. So one of our viewer requests that if you can share the cartoon with RBC morphologic abnormalities one more time and explain it. If you can share,
sure.
please.
Absolutely. So can you see now the presentation?
Yes.
Okay. So yeah, this is the different morphologies. This is the cartoon. Yes. These are different morphologies. Yes, exactly. So the morphology here, we can see microcytic anemia. It's smaller than the normal red cell size. Or if we compare it as an internal control, we use the normal lymphocyte as our internal control. If it's smaller than the normal resting lymphocyte, we call it microcytic. If it's bigger than the normal resting mature lymphocyte, we call it macrocytic. Causes of microcytic anemia, I love to memorize it with this acronym or mnemonic: iron deficiency anemia, anemia of chronic C, sideroblastic anemia, and thalassemia, or FAST. That's my own personal mnemonic to memorize this. The causes of microcytic anemia. Macrocytic are much easier: B12 or folate deficiency, liver disease, MDS, and chemotherapy. Spur cells with or acanthocytes with these long spikes going on here, and I gave that mnemonic. Burr cells or echinocytes, we see it a lot in the peripheral smear. As an artifact, this is the most common thing, so please do not rush to diagnose of Burr cells. Make sure that's not an artifact. If it's not, so it could be liver disease or renal failure. Schistocytes is commonly seen in microangiopathic hemolytic anemia or mechanical valve. Bite cells, we see it in hemoglobin, the G6PD deficiency. Elliptocytes can be seen in hereditary elliptocytosis or iron deficiency. Spherocytes, we see it in two conditions, hereditary spherocytosis, or autoimmune hemolytic anemia. We can do the direct Coombs test to make sure it's not autoimmune. And stomatocyte can be seen in stomatocytosis and liver disease. Target cells seen in thalassemia. It can be seen in alcohol, can be seen in liver disease, can be seen in iron deficiency anemia, it can be seen post-splenectomy. Sickle cell, as I showed, picture sickle cell or either disease or mix between sickle cell and C, or sickle cell and D, or sickle and beta thalassemia. Teardrop with myelofibrosis or any bone marrow infiltrated process, including carcinomas or any fibrosis or anything that's replacing the bone marrow. Hemoglobin C crystal, we can see it in hemoglobin C or SC. Red cell agglutination, as I showed in a picture, was called hemagglutinin disease, or paroxysmal cold hemoglobinuria, or IgM lymphomas, associated lymphomas, and multiple myeloma. And Rouleau, definitely you can see it in multiple myeloma, but also can see it in any chronic infections. Yeah, and these are the inclusions.
Thank you. Thank you, Dr.
Sure.
Meawad. There is another question. Is lysozyme in IHQ useful for diagnosis of AML CD34 negative, MPX negative?
Sorry, is what, sorry?
Is lysozyme in IHQ useful for diagnosis of CD34 negative, MPX negative AML?
Yes, and we use that combo a lot, the use of lysozyme and MPO. This combination together in a lot of AML with monocytic feature, especially the tricky cases of 34 negative AML. So yes, definitely we can use the combo. We just don't use lysozyme. We use lysozyme and MPO for the two lineages, granulocytes and monocytes. This is the combo we use in 34 negative acute leukemias. That's right.
Thank you. There is another question about hemoglobin A2 and thalassemia. Can you please elaborate more on that?
Sure. So hemoglobin A2 is basically composed of two alpha chains and two delta chains. So lack of any one of these chains can cause decrease A2. So let's say, for example, patient has alpha thalassemia. Alpha thalassemia means there is no production of alpha chains. So the A2 will be low because there is no enough A2 because it's composed of two alpha and two delta. So we are missing the alpha chains. Delta thalassemia, the same thing. If we are not forming the delta chains, we are not able to form hemoglobin A2 because it does include delta chains in its formation. Beta thalassemia, on the other hand, beta thalassemia, the problem is in the beta chains. So we have alpha chains, but we don't have beta chains. So we have to form something else as a compensation. So either alpha chains and gamma chains and we form hemoglobin F, or alpha chains and delta chains and we form A2. So in patients with alpha thalassemia, they tend to have elevated A2 and F. So in the patients with beta thalassemia, if they have beta thalassemia and any other cause of low A2, that can confuse us. Let's say we have a patient with beta thalassemia and iron deficiency anemia, or beta thalassemia and delta thalassemia, for example. So these combination or these combos, one of them cause increased A2 and the other one cause decreased A2. So it can mask the defining feature of beta thalassemia by hemoglobin electrophoresis, which is the elevated A2. So this is also a tricky question. Yes.
Right. I'm checking if there is any other question online. Just 1 second.
Sure.
So regarding the acute myeloid leukemias and the different genetic abnormalities, so what are the important ones that one should remember while preparing for boards? That's one question.
Yeah, so that's actually a really good question. The most important three, I should say, are the ones that do not need the 20% cutoff. So that's an easy way to remember. So 15-17 translocation or PML RARA, that's the most common one. I mean, the most common for your board exam, which is acute promyelocytic leukemia. This is extremely definitely important because it's a medical emergency. You need to be aware of And also A21 translocation, you should be aware of this one, and inversion 16. These are the three common ones. Others can show up, but less common, but anything definitely can show up on the board exam.
Right. Dr. Meawad, there is one question about mastocytosis you said that CD117 is a mast cell marker, but it is not a marker of mastocytosis. So, and one has to rely on CD25 and CD2. Is that correct? So can you elaborate on that?
So CD117 can be seen, in both neoplastic and benign mast cells. So it's not, its presence doesn't necessarily mean these mast cells are neoplastic. The CD117, when we do CD117 on the bone marrow, it highlights the early erythroids and myeloids was very devastating, but the mast cells should bob up brighter than the myeloids and erythroid. But this does not mean that they are malignant. They're just mast cells, benign mast cells. So CD117, my take-home message is CD117 can be seen in both benign and neoplastic mast cells. On the other hand, CD2 and CD25, and most recently with the fifth edition of WHO, CD30, these are only present on neoplastic mast cells. You should not see them on benign mast cells.
So what about CD30? So you said that CD30 is also
now it's being included. Yes, now it's being included, but I don't think that might be on the board exam for this year. Probably 2024, because that's one of the recent things. And also the KIT mutation, they used to say the 816, the 816V. Right now, they are including any KIT mutation as a diagnostic criteria. So yeah, I think these updates you shouldn't worry about for this spring exam season. But yeah, there's some definitely changes and the next generation should be aware of.
Right, thank you. One of our viewer has a request for you that if you can elaborate a little bit more on MPN and MDS. Yeah.
Sure.
If you can elaborate a bit.
Yeah, absolutely. So MPN and MDS, we have certain categories for MPN and MDS, like a typical CML, which I mentioned earlier about the disc granulopoiesis and lack of BCR-ABL. And also there's some other categories, including the chronic myelomonocytic leukemia, or CMML, which is also a lot of monocytes. We can see some pro-monocytes, and if they increase enough all the way to 20%, we call this acute myeloid leukemia. Juvenile myelomonocytic leukemia is also one other category. Myelodysplastic myeloproliferative neoplasm with ringed sideroblasts and thrombocytosis, that's a fourth category. And then if it doesn't fit all of these, we call it unclassifiable. I think the best approach for these categories and for all these categories of myeloid neoplasm, that's what I used to do for my board preparation. I put the major criteria and the minor criteria for all these categories in one table. So you have all MP and MDS in one table. So you know what's the major criterion, what's the minor criterion, and if there is clonal or genetic abnormality associated with each one of this. The table format will make things much easier and will help you with the exclusion criteria, which are really important in this condition.
All right. I think thank you so much, Dr. Meawad. The questions, these are the ones that I saw online on Facebook and YouTube. And thanks again for this excellent rapid review of such a vast topic of hematopathology, so including leukemias as well as benign heme and hemoglobinopathies. I am sure the trainees would find it useful as they go through some rapid material for their HemPath review. And so thanks again. So we had quite a few viewers who joined online on both Facebook and YouTube. And thank you, Dr. Meawad, for your time. Tomorrow for the viewers, so we have another board review session. So we will have Dr. Yasmin Butt, who would be joining from Mayo Clinic, Arizona, and she will be presenting a board review session on pulmonary pathology. And that would be at 12 p.m. Eastern time or 9 a.m. Pacific time. So hope to see you at that time. And thank you again. Thanks so much.
Thank you, Dr. Manan. Thank you very much, and
Thank
good
you so
luck
much.
everyone taking the board. Thank you. Have a good
Thank
day.
you.
Thank you. Bye-bye.